Welcome to the workshop, Limiting Late Effects Following a Transplant Using Donor Cells. My name is Marla, and I will be your moderator for this workshop. Before we begin, I'd like to thank Sanofi, whose support helped make this workshop possible. It is my pleasure to introduce today's speaker, Dr. John McCarty. Dr. McCarty is the Medical Director of the Cellular Immunotherapy and Transplant Program at Virginia Commonwealth University, Massey Cancer Center in Richmond, Virginia, and the Medical Director of the Cellular Therapeutics Laboratory. His clinical work focuses on treating patients who have leukemia, multiple myeloma, lymphoma, myeloproliferative syndrome, or bone marrow failure disease. He also specializes in cellular immunotherapies for autoimmune diseases. Please join me in welcoming Dr. McCarty.
Thank you for that very kind introduction, and I'm very pleased to be part of this excellent symposium that provides so much good supportive information to patients that have been through transplant, for patients that are considering going through transplant, for caregivers, as well as other providers who support our work in transplant and cellular therapy. I will be speaking to you this afternoon about not just surviving allogeneic transplant, but actually what can we do to have people thrive and really excel in their quality of life after undergoing allogeneic transplant. So the first thing I want to discuss is what is allogeneic transplant for those that may not know. So this is different from other kinds of transplant treatment and cell therapy in that the stem cells that we are doing and the blood cells that we're using to carry this out come from either a related family member, an unrelated donor, or potentially even a cord blood donor. And we can actually derive these from harvest from bone marrows, from peripheral blood stem cells, processing the blood, or from bank cord blood. Now, it's much more than just giving someone a clean bone marrow. What we're also adding in is a new immune system. The cells from the donor are moving into the system, into your body, and they're going to be less tolerant of the cancer being treated. I often use a lot of imagery or analogies with my patients. I often say it's almost as if your donor moves into your body, into your new house, looks around, says, nice house, I can live here. But it's going to want to do some renovation, and the main thing it wants to do is to look at that bone marrow or look at that leukemia or lymphoma or myeloma or whatever we're treating, and we want it to reject that cancer. And so it's one of the most powerful immune therapies of cancer that we have at our disposal. So it makes it much more than just getting a clean bone marrow. So there are different pieces. First, you need to have upfront chemotherapy. We call it the preparative regimen or the conditioning regimen. And the purpose there is to make room in the bone marrow for the cells to be able to plant, and likewise to suppress the donor's or the recipient's own immune system so that the new immune system from the donor can actually move in and start doing its job. The cells are infused intravenously. The cells have their own GPS. They circulate around, they go back to the bone marrow, and they start filling in and start growing. In order to prevent rejection or to prevent the donor from perhaps trying to react against more than just the cancer, there are immunosuppression medications that are used, and the duration and the type of medicines are very much individualized to the patient and the type of transplant and the donor that's being used. Compared to other kinds of cell therapy, there's a longer period where the immune system will not be perfect. And so there are a lot of lifestyle changes to reduce some of the risks. We're trying to reduce infection and likewise trying to reduce an overreactivity of that donor's immune response against the cancer, which would be called graft-versus-host disease. So how do we, once you're through, what about post-transplant care? This is actually also very individualized. More and more transplant programs are setting up long-term follow-up programs and survivor follow-up clinics. We actually here at VCU Massey Cancer Center, we started a long-term follow-up clinic for more than 15 years that includes more than just the transplant physicians and nurse practitioners and PAs. It also includes transplant focused physicians and specialists in endocrine and psychology and psychiatry, endocrine, pulmonary, kidney diseases, infectious diseases, and so on, so that patients that might need those extra levels of expertise will have essentially one-stop shopping, and we can continue to follow if that supportive care is needed during any of that time. So the duration and the type of post-transplant follow-up for each patient is very individualized, but it goes for at least 10 years. And we'll certainly, in the very beginning, looking for disease status. Are we staying in remission or not? That typically is something that occurs in the first 5 years. For many of the things that we transplant, we are very focused within the first 2 years. And certainly for many of the diseases, usually a cure consists of a remission that lasts in 5 years. So we also may use certain treatments to prevent relapse, depending on the disease and what are the little engines, if you will, in the cell that are driving that particular cancer. Then we also start looking at prevention, diagnosis, monitoring, and treatment of any graft-versus-host disease and treatments that might enhance or improve reconstituting a healthy immune system. And then after that, we're doing a lot of health maintenance, looking for maintaining organ health and overall health in patients that have walked the cancer journey. Some of that will start in the transplant program in the long-term follow-up clinic, but this would also be a partnership with your local physicians, either your local oncologist or your local primary physicians working in tandem with us, as well as our transplant-focused specialists. There are a number of, the National Marrow Donor Program has put together a number of guidelines for post-transplant care. This is actually guidelines for both patients and physicians. So on the slide, you see here both things you can, QR codes that you can scan, but also links that you can go to those resources as well. So what are some of the long-term consequences of chemotherapy or going through the transplant experience? Well, it depends on the specific type of chemotherapy and if radiation is used, what dosing and where. We look at metabolic and endocrine health. We're looking at the immune system and how it recovers, as well as the risk of infections. We look at impacts on fertility. We're looking at impacts on heart health and lung health. We're watching for potential for the small but non-zero risk of secondary cancers. And then we're also looking for, getting back into life, social and work functioning and family functioning back to a level of interaction that is satisfying and improves your quality of life. So we'll go for a few of these in some detail. So recommended long-term screening, because the idea is there are things we can do to try to prevent, but then we also want to do monitoring so that we can identify things early, or as I call it, fix it before it breaks. And so regular cardiovascular screening, management of your lipids, the cholesterol, the triglycerides, monitoring your blood sugar, and monitoring and doing adequate care against your blood pressure. Just because the cancer is cured doesn't mean that the rest of health issues that occur as we age or as we have different risks, we don't want those to get in the way of your quality and quantity of life, frankly. Because the skin very often has been exposed to the chemotherapy or radiation, we want to watch the sun exposure. Patients going through transplant may at times be on antibiotics or other treatments that might actually increase your risk of sunburn and sun injury. So we recommend that patients get annual skin exams, and if you're someone that's had previous skin-related sun injury or sun damage or prior skin cancers, then obviously more frequently as that would be indicated by your dermatologist. As far as endocrine, We recommend at least an annual thyroid function test, looking at the hemoglobin A1C, which is a measure of your sort of your long-term average glucose control, sugar control, testosterone, estrogen levels. The timing and how often we check it really depends on the risk and the clinical course, but at least annually, simply because that can have impacts in terms of energy levels and general sense of well-being. As far as the GI tract and the blood, for GI, we recommend an annual liver function test. More frequently, obviously, if someone has risk factors before we go into it or before we go into transplant or go into long-term follow-up. For example, someone that has a history of hepatitis B or C, making sure that this is not reactivated, previous cirrhosis. Likewise, in many Caucasian patients or patients that have a large number of transfusions, iron overload, which is what I'm going to talk about in part of hematologic, but that also can have impacts in the liver. And anyone that had graft-versus-host disease involving the liver very often will need to be followed a little bit more closely. We will always check a complete blood count at each visit out for the 10 years, and we will be monitoring for iron overload, which is a simple blood test that could be looked at. Musculoskeletal, so people with chronic graft-versus-host disease don't always have, but may have some thickening and tightening of the connective tissue or the skin over joints, and leading to some decreased range of motion or stiffness. And in that situation, identifying it early, intervening early, but also doing regular exercise, not just strength training, but much more focused on range of motion and flexibility, is actually very key and critical towards limiting this issue from, again, limiting your ability to do what you would like to do once you've completed transplant. What about immunity and infections? Well, there are protocols. I know there's a lot of controversy about vaccinations, but when we do this kind of a transplant, you have to assume that we have completely erased your entire immune system memory of what you have ever been vaccinated for, okay? So even if you've been vaccinated for COVID and the flu, your new immune system will not remember that. And so beginning at 3 to 6 months post-transplant, vaccinations for COVID and flu, for pneumonia, for meningitis, and then later hepatitis, diphtheria, tetanus, and polio, mumps, measles, and rubella, shingles, all are appropriate at different times. There are different strategies and timing based on each center about how to do this. In other words, many right ways to do this. So this is something I would check with your local transplant physician and long-term follow-up team to determine when these all should happen. COVID and flu, we've done a national study with the Center for National Blood and Marrow Transplant Research. I mean, this is the global, we have multiple transplant programs. And we have seen that it is safe and beneficial to do the COVID and flu vaccine starting at day 100. Many times, hypogammaglobulinemia, what does that mean? Your antibody levels may be low, partly because of, again, the impact on while your immune system is trying to recover. If you've had graft-versus-host disease, some of the immune suppression medications may impact that. So we may consider, your doctors may consider giving you a bag of plasma or immunoglobulin when the levels are under 400, and especially if you're having frequent sinus or pulmonary infections, this has been able to reduce the severity and incidence of those infections. In many cases, you will be on preventative antibiotics, antiviral and antifungal, again, with the duration based on when your immune system actually becomes more intact and more robust. What about other organ systems, long-term screening? Well, for the eyes, obviously ocular exams for any symptoms. And interestingly, graft-versus-host disease of the eyes is not just about having dry eyes. Sometimes new onset of having bloodshot eyes, or suddenly, man, my eyes are just tearing like crazy. I don't understand. As well as a sense of feeling dry eye. Not all dry eye is graft-versus-host disease, but not all graft-versus-host disease is dry eye. So very often it's good to have an ophthalmologist who have these symptoms. Sometimes having an ophthalmologist that is familiar with transplant patients is very good to evaluate if you have any of these symptoms. But if someone has had radiation, if they've had graft-versus-host disease, or long-term steroid exposure, it's good to have even annual regular exams, simply because there may be an increased risk of cataracts that may need to be monitored or treated. As far as kidney function, some of the medications, both chemotherapy, antibiotics, the immune suppression can sometimes interfere with kidney function, sometimes temporarily, sometimes more long-term. And so again, at least following annually to make sure that everything is staying stable, or more frequently depending on the individual course during transplant. As far as GYN, having regular exams, this is true for both people that are premenopausal and postmenopausal. There is such a thing as graft-versus-host disease of the vulvovaginal area, and it is uncomfortable and is something that can be treated preemptively, but having someone follow both during the transplant period and afterwards is important. Not everyone has had the benefit of getting the Gardasil vaccination against the human papillomavirus that has been associated with cervical cancer. So during the period of immunosuppression, or when the immune system may not be completely normal, that could be an opportunity for that virus to reactivate and potentially lead to a cervical dysplasia that can be treated pretty effectively if it's caught early. Especially women who have had radiation therapy, mammography is very important. But again, just keeping up on what is the usual and standard health maintenance is very important because you did the transplant in order to maintain excellent health. So let's make sure nothing else happens. Okay, so that's very important. Bone loss. So this is something we follow very closely. Avascular necrosis, which meaning that the bone loses some blood supply to it, so the bone actually deteriorates and may actually even collapse. It only happens about 5 to 10% of patients, and it's usually associated with very prolonged or high dose uses of corticosteroids like prednisone or methylprednisolone. It's more likely in the hips, a little less often in the ankles and shoulders. We are doing gene therapy and transplant for people with sickle cell disease, and they very often, because of their sickle cell crises, may actually have an increased risk of avascular necrosis, which may actually be more related to the sickle cell and persist during the transplant. Immunosuppression medications, cyclosporin, tacrolimus, and sirolimus, those medications also can contribute to some bone loss and bone thinning. And frankly, being sedentary, okay? Your body gets in a mode where if you're not using it, you're going to lose it. And so bone thinning can occur in 50 to 60%. 20% of these people will actually progress on to true osteoporosis, and people may develop symptomatic fractures in 1 to 5%. Those may not seem like big numbers, but it happens to you. It's a pretty significant thing. So what are other risk factors? Well, family history. Many patients' families will often have increased chances and severity. Patients who may lose testicular function or ovarian endocrine function because of the chemotherapy, early menopause, if you want to think about it, very often are an increased risk because estrogens and testosterone is actually protective against bone loss. Prolonged use of growth factors because of low blood counts can also, that's an unusual reason, but that also can contribute to some bone loss. And when the kidney is not perfectly functioning, it has a role in managing calcium storage and bone health, and so that may also be contributory. So what can you do to prevent this? Well, let's do the testing. Bone density testing can be done every 2 years, and because of recommendations, really isn't done more frequently. And if someone is found to be at risk or actually have osteoporosis, there are medications that are used post-transplant that are also used for people that have osteoporosis for a variety of reasons. Calcium and vitamin D. The level of the vitamin D is really based on the blood levels of vitamin D. Then talking about hormone replacement therapy in both men and women. That's why we follow those endocrine levels. And that risk and benefit must be individualized. Obviously, someone who may have had a previous risk for breast cancer or may have been treated for breast cancer, there may be better ways to do this without necessarily increasing the risk of reactivation or recurrence of the breast cancer. What I can't speak more highly about is exercise. Exercise, okay? Before, during, after chemo, and after the transplant. It's really important. We're not looking for people to, beat Usain Bolt at the next Olympics. I really don't care if, while you're doing your walking, if snails run right past you. But you want to focus on core activities, so things like yoga, Tai Chi, Pilates. You can do Richard Simmons and Jane Fonda, but you don't have to do it as fast as they do. It's time-focused, scaled to your energy levels, and you want to do a minimum of 30 to 40 minutes a day as a continuous exercise. So core, or is what I talked about, cardiovascular is walking, treadmill, exercise bike, elliptical. Any of you that happen to have, whose children or grandchildren happen to have a gaming system, very often the Wii Fit, or some of them will have exercise programs. Even that very silly game of playing Just Dance or Dance Dance Revolution, believe it or not, is core exercise. So you can make it fun, find it, mix it up, do one of those exercises every day, but commit to doing that for the rest of your life. There's a very important impact on bone loss, and I'll talk more about that later, other benefits as well. Please look to hear more about this with Dr. Stamatuli, who is one of my partners. She's an endocrinologist in our clinic, and she'll be talking to you about this on Sunday. Sexual function. So related to chemotherapy and radiation, males and females can undergo through a version of menopause. It's very common. Most common with total body radiation, as well as I mentioned, high-dose Cytoxan. Sexual function can be impaired with these hormonal changes. You can lose lubrication. The vaginal mucosa can become thin, and that actually is one of the risks potentially for vulvovaginal graft-versus-host disease, and leading to very painful sexual function, but also can reduce the flexibility or the stability of the pelvic floor, leading to more problems with incontinence and other issues. Low testosterone may be associated with lower libido. So the replacement, really needs to be discussed with your doctors. There's a multidisciplinary approach. For vaginal mucosal thinning, you don't have to necessarily do full-blown systemic estrogen replacement, but very often even estrogen creams that are given intravaginally is enough to reduce a lot of these issues as well. So I think more detail you'll hear at a specific workshop addressing these issues. Dr. Lawson will be speaking about this later in this symposium. What about fertility? Infertility is not a certainty, okay? You may recover. Many patients have been able to recover. Again, as we talked about with the issue of high-dose Cytoxan and total body radiation are often associated with higher rates of infertility. And it's more of an impact on women than men. So we often talk about sperm and egg banking prior to transplant as an option to be pursued for people that would still like to have children after the transplant process. There's a link here from BMT InfoNet talking about fertility options after transplant that I would encourage you to look at if you have an interest in this area. What about issues with the lungs? So there is potentially some pulmonary scarring that can happen. It can happen with certain chemotherapies. Can also happen from radiation scatter if areas of the chest or the neck, that can also occur. When we call it engraftment pulmonary inflammation, that is something that can occur when the cells are engrafting, especially in people that might have previously smoked or had some other prior inflammation with the lungs, those new cells coming in, that new immune system coming in at the time of engraftment can sometimes cause a little bit of pulmonary injury as well. That can be treated very effectively if it's jumped on early. Lung can also develop graft-versus-host disease, and that's where identifying early and working with a BMT-focused pulmonologist to treat this is very, very important to, again, preserve as much lung function. Some people actually have to have surgery on their lungs. So, for example, situation I've seen is they remove a part of the lung is removed because they had a fungal infection. They have to remove it. Sometimes if an area had to be radiated because of prior breast cancer or lung cancer, that area of the lung may not be as functional. And sometimes because of graft-versus-host disease, infections, and so on, the lining around the lungs can become thickened or can adhere together, or fluid can collect around the lungs that might compress the lung function. What can I do? Well, another reason exercise is important because it's beneficial in getting you the most out of what you have, but it's also a vital sign. So please report any changes in exercise tolerance. Hey, doc, I used to walk around my neighborhood and I could do it in 20 minutes. Now it's taking me 30 or 40 and I'm feeling a little more short of breath at the end. Well, before we actually see you really have a major problem, that gives me an early warning sign to look into it, to check into it and see if there's something else, okay? Likewise, with the ongoing follow-up, we will do screening pulmonary function tests and high-resolution CT scans for at-risk patients. That's where we have the pulmonary BMT service embedded in the clinic to look at it. We want to jump early on any inflammatory pneumonia or pneumonitis that we might see. And then whenever the pulmonary function tests show even an asymptomatic decrease of 10%, we often start a protective therapy and send patients to the pulmonologist to be followed very closely to make sure that we're making a good impact on preventing any further lung injury. Big one is don't start and don't restart smoking. That includes primary use smoking and secondary smoking. It includes, to a certain extent, I remember in Seattle where I trained, a lot of people used wood burning fires or wood burning ovens. And, if it's anyone like the one I had, sometimes there's a little leak and that particulate matter can actually lead to some issues. Vaping is as bad a risk as smoking, and in some ways it's even worse. So that doesn't help you, okay? It's not protective. So ideally, stop smoking before you get to transplant, the longest period of time between the last cigarette and when you go to transplant, but also not starting again will actually allow you to maintain good pulmonary health so that you can do all the things you wish to do. So on Thursday afternoon, Dr. Cheng will be talking about this in much more depth. Cardiac risks. So heart attacks have been seen after chest radiation, but not total body radiation. Okay, it's a more focused, high intensity chest radiation. After treatment, some of the risk of heart attack come from hormonal changes. Estrogen levels in the blood actually are protective against cardiac disease. Some people may actually develop or even have, going into transplant, something called metabolic syndrome. And that's sort of insulin resistance, or we call it adult onset diabetes, high blood pressure, high lipids, abdominal obesity. That basically puts you at some risk. And looking at that as a unique way of treating patients, not as just the individual components, very often results in better outcomes. Some of the chemotherapies could cause congestive heart failure. Anthracyclines, which we really don't use in transplant, you might have had beforehand. And it may, less than 5% can occur with Cytoxan or melphalan, which is used in transplantation as well. We have a cardio-oncology service, and many other centers are seeing these emerge to help with these unique issues and needs. A regular cardiologist may not fully understand both in terms of clearing patients that may have some cardiac issues going into transplant, but also to help maintain and monitor and optimize treatments afterwards. And so we've had a cardio-oncology service for almost 10 years to meet the unique needs of cancer patients. Engage in regular recommended health maintenance checkups for your heart health, and again, report any changes in your overall health. If it helps, and this may make you laugh a little bit, but I swear this is exactly what I tell people, be a wimpy, whiny, sissy, complaining, girly man, bitch and moan and hypochondriac reporter, please. You are the best person to know how you feel. Any changes that are not for better, we'd rather hear about it and find out it's not something we need to worry about rather than wishing we had intervened earlier. So what about getting your immune system back and reducing your risk of infection? We talked a little bit about having low immunoglobulin levels. It's very common. In some situations with graft-versus-host disease especially, sometimes the spleen, which helps filter the blood from certain infections, that function may be reduced. And so during the transplant, I mentioned going on some preventative antibiotics, and a lot of that is to help with that. And that would continue until the immune system is able to be fully reconstituted. Anyone developing graft-versus-host disease, it might slow down the time at which, or prolong the time at which the immune system becomes fully functional and functions as a full immune system. Some people may need long-term antibiotics to prevent pneumococcal pneumonias. Shingles can reactivate in 20 to 50%, but that's why we use acyclovir. And when the immune system is normal, we give the Shingrix shingles vaccination. There's a type of pneumonia called PJP or pneumocystis. It can recur up to a year post-transplant. And so very often, until that immune system looks like it's able to handle and do its job of preventing infections, you remain on various treatments to prevent against that infection. We talked about vaccinations, can start them at different times, 3 to 6 months. Again, I've talked about the study looking at COVID and flu vaccine, because these are things that can cause very significant infections. I also recommend that caregivers are also fully vaccinated, because in our experience, 85% of the COVID and flu comes from close contacts. And so the way I talk about it is, if I can't, if you don't have an immune system, I can't protect the castle well, then of the people who are to be closest around you, I want to build a wall and I want to build a moat to make sure that their risk of infection and passing it on is as low as possible. And so there's another link here for you to look into the post-transplant vaccination guidelines from the Center for International Blood and Marrow Transplant Research. Secondary cancers. This is one that is very scary, but while it's a higher risk than the general population just walking down the street never having had chemotherapy or transplant, it is still a relatively low incidence to occur, okay? Cumulative incidence at 15 years is no more than 10 to 12%. It's still incredibly uncommon, and it's usually related to chemotherapy, more intensive conditioning, previous chemotherapy and radiation therapy, as well as certain infections. Epstein-Barr virus can lead to lymphoma. Hepatitis C can lead to liver cancer potentially, and hepatitis human papillomavirus can lead to cervical cancer. And the timing that we look for these are different. So looking at the Epstein-Barr virus types of lymphomas will actually occur while you're still at the transplant center within the first 100 to 1 year, 100 days to 1 year. Secondary blood cancers will occur within the first 5 years if they're going to occur. And then the concern for second solid tumors is really a much more long-term thing, looking out over 10, 20, 30 years or longer. All that means is stay, we'll talk about that, stay in touch with your doctors and do follow-up. So breaking it down for leukemia and blood cancers, again, 4 to 5% incidence. Median time is usually within the first year of transplant if it's going to occur. It's associated with the use of certain chemotherapies, typically not the ones we use in transplant, but ones that you may have received before, or very focused radiation therapy. We've also seen that if we transplant with an inadequate number of stem cells per kilogram of your body weight, that can increase the risk. and to a smaller degree, total body radiation or radiation in general can increase that risk. For solid tumors, skin cancers, breast cancer, oral cancers, central nervous system cancers, again, cumulative incidence is about 6 to 11% at 15 years, and it's the highest risk for younger patients getting transplant under age 10. It's related to the use of immunosuppression, radiation, graft-versus-host disease, and other viral infections. So what can I do? Health maintenance, and also to make sure that all of your physicians have a health summary from the transplant and have an ongoing communication as you're being evaluated. You're going to hear more about this from Dr. Pasquini in his talk on Monday. What about general quality of life? So physical functioning, especially in people who have been working, doing that ongoing low-level exercise, physical functioning typically returns to 75% of pre-transplant level at 1 year. 85% of people return to work or school, and only about a quarter have any kind of physical limitations which might affect some of their work after we go through the treatment. Usually it's associated with people with persistent graft-versus-host disease. The people who do the best are people who have good psychological health, and you can have good psychological health by again keeping in touch, exercising, and so on. And frankly, people going through transplant compared to people who didn't go through transplant, there are really no differences in family and peer relationships. Their school performance is usually pretty as the same, and self-esteem is actually very well preserved in the studies that have looked at this. There are some limitations. Many people feel anxious. I think anyone that has gone through a cancer and a cancer treatment, there's always the echo of concern. The vulnerability is there. And sometimes the relationship between the people that you love the most could change. And so having ongoing communication with your family members and taking advantage of counseling if that is an issue to make sure that you maintain the best quality of your life. Cognitive limits only happen in 19% of patients. It's actually more common in chemotherapy than in transplant. It's more common if you have other health issues. It's actually less likely if you have a commitment to work and that you like your job. Less likely if you have a good social climate. I know that very often we're all very concerned after transplant about resisting infections and trying to avoid infections. But the simple fact is, if you become a hermit and stay away from people, you're actually going to have more cognitive decline. So you want to prevent chemo brain. What can you do? That physical exercise we talked about. Mental activity is important. Safe social interaction is very important. Mental enrichment is key. So yeah, fine, you like to read. But you know what? You can add, you want to create more complexity and diversity to how you're doing your thinking. So do audiobooks and podcasts as well as reading. Use games to exercise other cognitive functions. Puzzles. There's a game called Lumosity, which actually exercises things. Having game night. That there's nothing to beat that social interaction of playing, Monopoly with your family and your friends, and that having a gleeful joy of haha, you landed on my hotel and now you owe me. Sounds like a small thing, but it actually does provide more diversity and kind of unclogs the potential for that chemo fog that can happen going through chemotherapy as well as through transplant. And so Dr. Nakamura will also discuss more on this on Friday. So tell me the good news. And we've been talking about all the things where things can fall off the bus, but the point is, this is all about making your remission count. We're not trying to make you focus on things that could go bad. We did this so that you could open your horizons. Limit yourself by what you can physically do, but not by what might or might not occur. You are so much more than your diagnosis, so much more than your transplant, so much more than the process that you went through. So don't focus on the cancer that was. Focus on the things that help you create a healthy future and get everything you can out of it. So take charge of your health and your well-being. Preventative care, early intervention means a better quality of life. Insist on communication between your healthcare providers and the transplant team. One of the best innovations has been having the electronic medical record, and many of these come with a sort of a my chart that you can actually share if there isn't the ability to actually access that between your various team members. Seek help wherever you need it in order to thrive. Social connections rule. Okay, they may be different, but they also can be better because you are somebody that did an incredible thing. Okay, reinforce the healthy behaviors after treatment and look to incorporating a positive lifetime lifestyle. Very important. You've accomplished an amazing task that most people never will have done. You are stronger than you think. You have done something pretty darn amazing. And that's something that you should appreciate and the people around you should appreciate as something that you have done. Ask for help if you need it from your family, from your physicians, from your friends, from counselors. And remember, you are a hero, period. So in summary, the number of transplant survivors are increasing. We also want to increase the number of transplant thrivers. More older patients are getting transplant. In fact, it's the highest, most rapidly expanding population of people going through transplant. Preventive health maintenance is the key to optimal post-transplant health. It's a multidisciplinary concern. It's not just the oncologist. Regular monitoring and health maintenance is all about prevention and more effective management of potential complications before they become more permanent. Stay engaged in long-term follow-up clinics. I know the last thing that you want to do after having been, hanging out with the transplant doctors for so long is to go back to that hospital again. But the protocols are there to support and promote your very best health. Thrivers and families who take an active role at all stages of treatment are able to ensure a healthy and vibrant lifestyle after transplant. So I'm going to stop there and see if there are any questions that I can further clarify with you. And thank you for your time and your attention for this presentation.
Thank you, Dr. McCarty, for this excellent presentation. Let's get to some questions. If you have a question for Dr. McCarty, please use the chat box on the left side of the screen to submit your questions, and we will answer as many of them as possible. So first we have, what are some of the problems with thyroid function that you will see with chronic GVHD?
Are you able to hear me right now?
Yes.
Okay, great. Well, so I think you can often see hypothyroidism, low functioning of the thyroid. And so part of our long-term follow-up is to, at least on a regular basis and at the very least annually, continue to check thyroid function. I have not seen things like Graves' disease and some of the autoimmune thyroiditises as a manifest, the way graft-versus-host disease shows up. But certainly that can be picked up in that way if we needed to. So I think just going on and doing the screening. But it's not a thing that we expect to happen unless someone potentially has been exposed to radiation therapy, either in that area or potentially with total body radiation.
Thank you. Is there hope for a normal life, going out without a mask in nature, making plans to travel?
Once your immune system has reconstituted and you've gotten the vaccinations that you need, that's exactly why we're doing this. And you talk to your transplant doctor about when that time is is advisable to do so. But that's why we're doing it. The bubble that we stay in during the time where you're at greatest risk of getting infections is to allow you to more rapidly get to where you can do the things that you want to do. Now, it varies. For example, it does take some time to give just the usual and standard vaccines. But if you're going to travel to a place that might need more unusual vaccinations, yellow fever or concern for malaria, et cetera, then what I advise you to do is to ask your transplant doctor to have you see an infectious disease specialist at a travel clinic that would specialize in, where are you going to be, what do you need to have, and they can discuss the pros and cons of vaccinations and prevention.
Thank you. Is strenuous exercise okay at T plus 180, like a 50-mile bike ride, for example?
That's a tough one. That's an individualized thing that it's not. I can't just apply that by yourself. Depends on where you are with the transplant, how much immune reconstitution you've done, how much your immune system is back together, what your platelets are, and so on. I think that one I would have to say I would ask. Hopefully, if you are entertaining being able to do that, you will have been working your way up to that with less intensive exercise to know that you can. Remember that this is not a really great time to have a bike accident and develop road rash and having to pick gravel out if your immune system isn't quite normal. So again, I would check with that's an individualized thing, and I would double check with your doc who knows your individual case the best.
Will eating an anti-inflammatory diet make a difference in cardiovascular risk, and do you have any thoughts on omega oils?
I think that's probably okay. I wouldn't do that right away because remember, some people may have a reaction. Some of the omega oils uncommonly can cause a change in liver function, and you just also want to check with the BMT pharmacist to make sure that there are no interactions. I would say that, for example, there's also a lot of focus on the gut microbiome, and I believe there's a talk in this session coming along, and that's actually a very good way of trying to improve immune reconstitution, energy management, and so on for your body. I'm not talking about probiotics. I'm not against them, but they don't really move the needle enough. But there are some naturally fermented foods, which I often recommend when people have their GI tract is sufficiently recovered. Things like sauerkraut, kimchi, sourdough bread, miso soup, kombucha, a really good balsamic vinegar, and so on. Those are very helpful. But in addition, you have to provide the right kind of food for the right kind of bacteria, which would be things like, I'm from the South, so, collard greens are a great source of things, of the right food to feed the right bacteria. Greens, smashed potatoes, meaning that you mash the potatoes with the skins on after they've been boiled or baked. And even benefiber, things like that also provide the right kind of substrate on which you can grow good bacteria. All of that actually does contribute to gut health, to cardiovascular health, to metabolic health, and to immune reconstitution, which is, that's a pretty good outcome there.
Thank you, Dr. McCarty. Next we have, are you aware of any non-live vaccines being created, or is there a possibility that the donor's immunity is sufficient that the titers come back showing some immunity for measles?
Well, yeah, maybe. So that's actually an excellent question. No, that's a great, and especially around now, that's very topical. So what our practice for reimmunization is that we know that at day 100, you'll get the flu and the COVID vaccination. We will give things like meningitis and the 2 kinds of pneumonia vaccinations around day 180. Excuse me one second. But then once we've seen some studies that suggest that your immune system is reconstituted, no graft-versus-host disease, some point after 6 months, and we're looking at certain lab tests that tell us we're ready. Our practice, which is not everywhere, but our practice is actually to do titers for the vaccines see if you have protective antibodies against things like polio, tetanus, diphtheria, hepatitis, and mumps, measles, and rubella. And we don't vaccinate for people. We don't vaccinate if you have protective titers. We can't always predict what is going to come through the transplant process. There's almost a kind of a secret negotiation going on between your old immune system and the donor's immune system. Some might also be informed by what minor exposures you may have had. But to my knowledge, you don't always need to have it. However, I'm not aware of any non-live vaccines for mumps, measles, and rubella. That's worthwhile having a transplant infectious disease doctor to kind of talk to, and then the decision as to when to vaccinate with those may really vary with whether or not there's an epidemic going on in your particular area or not. So that might also change the recommendations.
Thank you. How to know whether immune reconstitution has occurred or not?
So that's going to vary between different transplant centers, okay? I can only speak to ours. What we're looking for is, for example, and some of it is age dependent. I guess the way to say it is those of us like me who have gotten our AARP card already, it takes a little bit longer to get our immune system back in order than someone who might be, say, under the age of 30. Likewise, the age of the donor has a role in that too, in which younger donors, which is what we're all shooting for, is to find the youngest donor we can, whether it's family or partially matched or unrelated, because immune reconstitution will happen a bit faster. Typically, it takes up to about 6 months. So after day 180, our protocol is to start doing tests to see whether the immune system has reconstituted. And what we focus on is whether or not your IgG levels are above 250, unsupported, and whether or not there's a subset of T cells called the CD4 cells to see if they're above 250, ideally IgG above 400. And when we see that those are both within hitting those targets, then we feel that that you're probably immune reconstituted. That's when we do the titers, because the titers for all those vaccines I just listed in the previous question, we have seen that if we vaccinate people too early, or if we vaccinate people with those vaccines and they already have protective titers, we have seen a flare in graft-versus-host disease. So to us, it's a marker of whether or not someone might develop graft-versus-host disease from an infection or for vaccination or resuming more normal life. Different centers have different thoughts about this and different studies about this, but that's what we use at our institution.
Thank you. Next question. Is it frequent to have 2 allo transplants when it is necessary, and what can be done to avoid the second one? I guess it doesn't frequently happen.
Well, that's a tough one. So I'm not sure that it's a frequent happening. So what we're really talking about is recurrence. And I think that there's probably going to be talk later in this series that's going to talk about recurrence, I believe. So the options for recurrence really depends on what does the recurrence look like, what disease we're talking about. Is it a molecular relapse? Is it a shift in what we call the chimerisms, the ratio of cells being made by the donor versus the recipient, or whether it's a full-blown hematologic relapse where we actually can see leukemia cells or lymphoma cells or myeloma cells or what have you. Each of those get approached very differently. So, for example, sometimes just dropping the immunosuppression may be sufficient to take care of that if you're already on the immune suppression, just doing it more rapidly than usual. Sometimes doing something called a donor lymphocyte infusion, where we're actually adding back more T cells, similar to the way that you would add seasoning to the soup. You don't pour it all in. You kind of put a little bit in, you stir it, you taste it, and see where you are. So we basically give back some immune system cells and see if that gets you back into remission. Sometimes, though, that's not sufficient, or sometimes even though we do our best to match, even though we match the donor and come up with the best donor characteristics, sometimes the donor can't see the cancer there as well. And so sometimes switching to a second donor that may have a better handle on managing the transplant could be another option. But that's a very individualized thing. And it really depends on multiple factors, as I mentioned. That really is, again, another individualized situation.
Thank you. We have another kind of vaccine question here. Measles is spreading in my community. I'm not able to be revaccinated still post-transplant. Do KN95 masks work for measles, and how do we navigate this risk?
I think I don't know, we all lived through COVID, right? And I think that what you do is you do the same kind of precautions that you did with COVID. I don't know that I would necessarily turn to become a hermit, but I would be very cautious about the public spaces. I would make sure that you have hand sanitizer. I think the best thing you can wear is an N95 when you don't control the environment. If there are family members and I'm going to talk even more generally, it's not just measles, if you have young children and you recruit with the teacher or the daycare center, if there's a plague starting to run through the group, then perhaps you might wait and see what develops and take a little bit of time before you have close contact. I think the same kind of strategies that you did to remain safe immediately after the transplant, as we all did during COVID, would likely serve you best until we can come up with a better alternative.
Thank you. I think we have time for a couple more questions here. Is mowing a lawn or tilling a garden something to avoid after 2.5 years after my transplant?
Again, that gets down to whether or not your immune system has reconstituted, okay? So what we worry about, if someone's immune system is not really back to being robust, or if you're being treated with some low-level immunosuppression, or you have some ongoing graft-versus-host disease, you may not have as robust an immune system as your doctors would like you to have. The concern we have about mowing lawns and tilling soils is that's organic materials where fungi, fungus infections can come from, and so on. So that would be something I would check with your transplant doctor, who would have a better sense on what's the status of your immune system.
Okay, thank you, Dr. McCarty. I think that has to be our last question. We're towards the end of the hour. Thank you for this excellent presentation. And on behalf of BMT InfoNet and our partners, this was very helpful. And thank you, the audience, for your excellent questions. Please don't hesitate to contact BMT InfoNet if we can help you in any way.
Thank you for all the time and attention and for setting this up. It's a pleasure to be able to communicate with you all. Thank you.